2013, and 2014. So this is like your all's third training. So this is awesome. I'm so excited. So we are compliant with training and education on compliance for Allen County, that is for sure. How many have been to any of the previous trainings? Has anybody not? Has anybody not been to? Okay, so this is your first. Have you been to any of my trainings at any other services? Okay, so this is your first one. Okay, Allen County's taking compliance extremely serious. The Affordable Care Act of 2010 made compliance programs mandatory. Part of that compliance program is at least yearly training. So that's what we're doing. We're complying with federal laws for healthcare providers. My disclaimer is that this presentation was current at the time I published it. Policy changes frequently, so the links in your documentation, I've provided that you can actually go to a link where they would have updated information. So anytime anything with healthcare, you're dealing with any kind of rules and regulations, they change so frequently, it's very hard to keep up with them. So anytime you hear anything on healthcare, there's going to be a disclaimer saying, when I put this together, this was current information, but it could have changed this morning. So we can't be held accountable for changes that happen all the time. I'd heard that over 6,000 laws and regulations are changed on a daily basis. So how anybody's supposed to keep up with that is beyond me. The other thing is I'm not an attorney, so this is not legal advice. This is from my experience and my knowledge. I wanted to go over with you a new publication that came out in August. This is a CERT audit. A CERT is a comprehensive error rate testing. CERT audits are done to make sure that Medicare is paying claims correctly. So this is an actual audit against them if they're not paying claims correctly. So this was done on a nationwide basis, and this is the results from that. So the first thing they did is they put together the top 10 highest projected error rate. So basically, Medicare paid incorrectly, and when the runs were audited, they found problems with those runs and didn't feel that they should have been paid. So that's kind of what we're looking at. So this didn't go very highly for these states' Medicare program. So the top 10, Colorado was #1 in error rates, and their error rate was 89.4%. Now this is all healthcare industries. Kentucky made #10. So we're #10 in highest error rates. Now our error rate was 13.6%, which is quite a bit less than 89.4%. However, the Office of Inspector General does not like to see double-digit error rates. They want to see something 5% or under. So that is still way too high, and we need to get off this list. The other thing that they provided are, they did pie charts for types of errors. What kind of errors were they finding? What were providers supplying in their documentation that did not meet their federal guidelines? So that's what they looked at. Ambulance made 2 of the charts. So we have to take that very seriously. So my training today is going to be dealing with documentation for the most part, and how we need to make sure we're compliant with rules and regulations on documentation. So the 2 charts that ambulance services made, this is the first chart here, and this is ambulance services, this section right here, which is 19.81% error rate. And this is insufficient documentation. In other words, the documentation being provided did not have all the information on it that was required in order for Medicare to have paid those claims. The second pie chart we made is this one here. And all of this is ambulance service. At 89.06% error rate. Who wants to tell me what category that was?
Medical necessity.
Ding, 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 ding. Give Ed a star, absolutely. Medical necessity. And does that even make you wonder about that, medical necessity? Here's where a lot of the problem was, and one of the reasons I kind of changed my whole presentation around to focus strictly on insufficient documentation and medical necessity, is we're finding that for non-emergency transports, if you have a PCS, you're solely reliant on that PCS for medical necessity. That PCS is not your medical necessity. That PCS is that facilities form for ordering the ambulance service and their proof of medical necessity that they could order the ambulance service. It's not your document. You have to have it with your documentation, but there's no part of that document that is yours. You are not responsible for anything on that document. You're not responsible if it's correct information or incorrect information. You're only responsible to make sure you have it, and that is your only responsibility where that PCS is concerned. All documentation, reasonableness, medical necessity, everything else that the government requires on an ambulance run report is your responsibility to make sure it's on your run report and you have identified medical necessity. And so that's kind of where we're going to be going today, and I'm going to spend a lot of time discussing medical necessity and giving you some tools so that you have a clearer understanding of medical necessity. I've done a lot of research, and what I did is I pulled information that is actually published documentation from the federal government or from a Medicare program that lists medical necessity reasons for ambulance services, whether they're emergency transports or non-emergency transports. And I went through and listed them, every single one of them out. So what I'm going to be going over with you is not my opinion. It is not my opinion at all. There are things that are on this list that I wouldn't even consider being medical necessity. But there are things that the federal guidelines have said, these can be considered medical necessity, so we're going to use it. We are going to use it. And so I'm just kind of going to be going over things with you to help you understand that how you would determine medical necessity may be completely different than how we can determine medical necessity, and making sure we're putting that in our narratives or somewhere on our run report. When I did your audit, we went over medical necessity a lot with 911 billing. I went to 911 billing and spent a couple of days there and did your audit from there. And so we found some different things, and I think you've all already implemented all the information we found needed to be improved upon. And did you get a pick list for medical necessity so that they can just go through and pick off that, or have we done that yet? I think we're looking into doing that, so you have a medical necessity field with all of my different sentences in it, so it can just be picked on and it could just be picked out of that field. Okay, so one of the things I wanted to let you know that I'm actually providing lunch for you today, because I was very pleased overall with the audit. I felt like you all had done a great job. And so I'm providing lunch for everybody today and tomorrow. Just saying thank you for listening, and thank you for following policies and regulations and doing the best that you can for Allen County Ambulance Service. It's very much appreciated. Okay, so we're going to start with signatures today, and you all know these. A lot of this is just going to be an overview, and then we'll just focus on the medical necessity and incomplete documentation. Signatures. There are 3 different signatures that you're looking at. You're looking at crew signatures, a patient signature, and receiving facility signature. So that's pretty much it. And then you've got the PCS over here on the side for non-emergency runs only, where you have signature requirements for that too. So crew signatures. Who signs the run report?
We do.
Who's we?
The crew that's on the truck.
Okay, you've got 2 or 3 people on a truck. How many sign?
2 or 3.
2 or 3. Good. Who said that? Did you say that? Good job. 2 or 3. If you're on the truck, you sign the run report. Now, what I want you to make sure you understand. Yes, sir.
Does that include the students and observe riders? Just probably.
I'm concerned about employees.
Okay, okay.
Your employees.
Okay.
Okay? Okay, I kind of just lost my train of thought there.
I'm sorry.
Oh, that's okay. The crew signature. Okay. What I want you to understand on your signature, this is a legal document. You are signing a legal document. Your signature is on that legal document. You better take it seriously. You better make sure there is no wrong information on that document before you sign it. If you went to the bank to get a mortgage loan, you're going to be looking at that to make sure you're not agreeing to paying more than they told you were going to have to pay. You're going to make sure that however long you want that to be, whether it's 15 years or 30 years, that is correct. You're going to make sure that information is correct before you sign it. You need to look at your patient care report the exact same way. You want to make sure it's thorough. You want to make sure it's accurate. You want to make sure it's complete before you put your name on that form. Because 5 years down the road, if that run is subpoenaed, you want to be able to stand behind your signature and not get in trouble because you didn't take the time to read it and there's fraudulent information on there. So make sure you're looking those over and take pride in what you're doing. Make sure you're taking pride in every single thing that you are recording on that, doing it to the best of your ability, doing it accurately, thorough, completely, and then signing it, reading it and signing it. Signatures. So wherever there's a signature, you have to have a signature, somebody's signature. We don't care if that signature is readable. You just have to make sure it's a signature. A printed name. Have to have a printed name, and you have to have a date. So signature, printed name, and date. Now the printed name, can we put Julie RN on there? That's the receiving facility. Can they just write Julie RN? It's a yes or no question.
No.
Okay. Good job. No. We want a full name, first name, and last name. Initial for the first name and a full last name is fine. You can run into problems down the road for that. So just to make sure we're doing everything absolutely to the best we possibly can and going the extra mile, we want a full first name, full last name, and then for the receiving facility and the PCS, we also need credentials. So that's what you're looking at. If somebody's signing, whether it's you, the patient, the receiving facility, the PCS, full name, printed, a signature, a date, and on the PCS and receiving facility, credentials. No exceptions to those. Absolutely no exceptions. That's what you're looking at. So before you sign your patient care report, you need to be looking at your documentation to make sure everything has been obtained and obtained correctly before you sign off on your run report. In your PowerPoint, you have a signature one, and I've given links to the signature laws that affect you all for your, and actually Ed will have this on his computer, and I actually put the signature laws there. Documentation. Your ambulance services compliance efforts play a crucial role in cruise documentation. When your run is audited, will it be able to keep the reimbursement that you receive for the services you provided? There are several opportunities for checks and balances within an organization before any claim is submitted for reimbursement. Most often, a failure to properly reimburse represents several failures in the process. Now, what I want you to understand is when we talk about Medicare, Medicaid, the government billing, some of you just like want to glaze over and it's like, I don't do billing, I just want to know what I'm supposed to be doing with the patient. Well, unfortunately, that is not the case. No longer. When you're a healthcare provider, all of a sudden you've got all kinds of responsibilities you did not sign up for, but those are your responsibilities. The problem is when your billing company bills for a run and then that's audited and Medicare wants their money back, 99% of the time, it is not because of anything that the billing company did, that they billed it incorrectly, used any wrong modifiers or anything. It's because a lack of medical necessity or a lack of insufficient documentation, which comes back on you all. So the billing company is only as good as you are. They can only do what they know how to do, but if you're not doing your end, so what you're putting on that documentation is very, very crucial to billing so that that claim can be billed correctly and nobody's having to guess anything. So I'm wanting to make sure you understand that. Does your documentation support your claim for reimbursement? Every employee must clearly understand your role in creating and maintaining compliant documentation. So key elements to a patient care report. What the government is looking at, what it is your responsibility to make sure you are reporting very, very clearly on your run report. Now, I'm making another disclaimer right here, and I need to make sure everybody understands this. I am not telling you to stop doing anything that you are currently doing. Everything that you have been taught, whether in school, whether by Allen County, whether by other classes that you need to include on a document, you include those on a document. I'm just telling you other information that also is required to be on there and also needs to be on there. So just, quickly putting a document into place, a run report into place and signing off on it and going on your way, you can literally not afford to do that. You have to make sure you take the time and do it correctly. Must. Okay, so here are the key elements that need to be on there from a compliance only perspective, not a clinical perspective, not anything else. All of those are still required to be on there. This is strictly from a compliance perspective, what is required of you to make sure you have clearly marked on your patient care report. Origin and destination. Now the key with origin and destination is the address, a valid address, whether that is the corner of Highway 31 and I-65 or whatever. There must be a valid, some type of address with that. Now you have a pick list for your addresses, so your addresses should already have an embedded, correct address with them. And if that's not the case, that is something that needs to be looked at periodically to make sure the correct addresses were entered into the system to begin with. So that's something administrative staff needs to keep up with. But that address is very important. The other thing on your origin, can anybody tell me on the address what the most key element is?
Zip code.
Your zip code. If you're going to be dyslexic anywhere on your run report, do not let it be the zip code. Check it, check it, check it, check it. Make sure you've put the right zip code. The reason being is because depending on the zip code, there is a national zip code file that has every single zip code in the entire United States on it. And they have been designated as rural, urban, or super rural. So every zip code has a designation. Depending on what designation that zip code is, depends on how much you get paid per mile. And that ranges anywhere from $6 to $17 a mile. A huge difference. And I would say Allen County probably fits into all three categories depending on the zip code. So you want to make sure you're getting the right zip code on your run report. And this is for the origin only. Odometer readings. Odometer readings must be recorded in the tenths. 0.1, 0.3, 0.5. If it's consistently 0.0, then we've got a problem. Occasionally, a 0.0 may happen, but for the most part, it won't. If your trucks don't record in tenths, then you need to be using your trip odometers to make sure your run report has your odometer readings recorded in the tenths. Okay, now then 3 things: dispatch complaint, patient's complaint, and crew's primary impression. These are 3 different, like, patient condition kind of things. Patient's condition at the time of dispatch, patient's condition on what they tell you in the scene, and patient's condition what you are observing. So you've got 3 different things there dealing with patient's condition. All 3 of those need to be clearly defined on your run report. They don't have to match. They don't have to be related in any form of fashion. They just need to be true and accurate and very precise on what they are. Now you have drop-down lists where you actually pick a condition on those 3 fields. So you're picking something, and that's fine. I have no problem with that. The problem I have is if that list isn't completely complete and you happen to pick a generic code like sick person, general illness, other, not available, anything like that, that's fine to pick those. That is not a problem in any form or fashion. But when you do, you better make sure your narrative states dispatch complaint was, or patient's chief complaint was, or my primary impression is. Make sure you're clearly defining it in your narrative. So if you're having to pick a generic code out of your pick list that doesn't fully describe that patient's condition, you better make sure it's in your narrative. That is probably one of the biggest insufficient documentations there is that those things aren't being clearly defined, and things like other, sick person, general illness are being left alone to describe whether it's the dispatch complaint, patient's complaint, or primary impression, and you cannot do that. You have to be as thorough as possible. It's just like when we get to medical necessity, bed confined. Used to, it was fine to put patient is bed confined. That's all they needed, didn't need anything else. Those days are long gone. That is no longer sufficient. Now you have to list why the patient's bed confined. So your whole documentation, you need to be thinking why, you know, what's going on here, and be very, very concise in your narrative. Now, if your pick down list says respiratory distress, and that's what it was, that's fine. Chest pain, that's fine. Back pain, you know, that's fine. So I'm just talking about those generic ones where somebody's scratching their head going, so what was wrong with the patient? Why were they sick? What kind of general illness were they having? What's other? What does other mean? So just those things that need to be more clearly defined. Reasonableness. Anybody remember what reasonableness is? You have medical necessity and reasonableness. Does anybody remember what the difference between the 2 are? Medical necessity is what is the condition of the patient that is requiring them to be transported by ambulance. That could be a condition that is not related to why they are going anywhere. Reasonableness is why are they going. Not how they're getting there, but why are they going there. So if they're going from their residence to the hospital because they fell and hurt their leg, that's why they're going, and that's the reasonableness. The medical necessity, their leg may not be injured to the point where they would require an ambulance, but they could be a dementia or Alzheimer's patient, and so they have to be transported by ambulance, and then that's your medical necessity. So you have to make sure that you're understanding that the two do not correlate. So when somebody stubs their toe and they're calling an ambulance, and you get there, they've got a stubbed toe, and you're thinking, why in the world did they call an ambulance? You need to find out what their medical history is. What is their background? Why do they have to go by ambulance? And a lot of times there is something. It's not physically being able to see it, so you have to understand what you're working with on those. The other thing that I want to make sure that is clearly on there is procedures are recorded and findings. Every procedure, treatment, anything you do, make sure it is being recorded and make sure you're giving the results of whatever it is you're doing. Very crucial. If it wasn't recorded, it wasn't done. If you don't record it, it wasn't done. I don't care if it's on any other kind of document or anything. If it's not on your patient care report, it wasn't done. So make sure you're recording them. That's just the way the government looks at it. If it wasn't recorded, it wasn't done. They're not going to go look and say, oh, well, the PCS says IV fluids are required. Now remember, that PCS isn't your document. Somebody else has said IV fluids are required. So if your document doesn't have anything on it where IV fluids were done or anything, then it wasn't done. It doesn't matter you were told that it was required. Plus, now you've got another problem. You've got a problem if that's runs audited and something happened because that patient may not have gotten some kind of treatment. You've got information now that you didn't provide the treatment that was told was required of you. So make sure you are recording everything that you do, period. Do not rely on any other piece of paper in that whole scheme of things to establish what you did, because if you don't record it, then you didn't do it. Okay, the patient care report paints a clear picture of the dispatch complaint, the scene, the patient's complaint and condition, the crew's primary impression, symptoms, what the services the patient was provided, why those services were medically necessary, and how the patient responded to those services. So everything needs to be clearly painted. Subjective conclusions about the patient's condition, never, ever, ever do. Crews must document objectively what they observe. Avoid personal opinions and unsupported conclusions. Now here's a good piece of information. Whenever possible, be both quantitative and qualitative, such as patient describes the pain as sharp and stabbing. Patient rates pain an 8 on a scale of 1 to 10. So anytime the patient is complaining of pain, I don't care where that pain is, you need to be finding out how they describe that pain as far as whether it's dull, aching, stabbing, sharp, whatever, and where do they rate it on a scale of 1 to 10. Very important information. For instance, let's say you are dispatched for patients has their leg is in pain. They have pain in their leg. So that leg pain is not necessarily a ALS complaint, but it could be depending on where that patient rates that pain. So you get there and you ask the patient, you know, how do you rate your pain on a scale of 1 to 10? And they say a 7 or above, then if you do an ALS assessment, you can charge for that ALS assessment. So that's why it's very important to know where they rate that pain and make sure you're putting that on there. Internal consistency. Ensure your patient care report does not contradict itself. After you write it, read it. Ensure that it is internally consistent between different sections, different crew members. Recheck it if there are any inconsistencies, and each crew member should take personal responsibility for everything on the patient care report. Examples of inconsistencies. The patient is awake, alert, and oriented to person, place, time, and event. no neurological deficits, equal grip strength, able to articulate sentences, normal speech pattern, vital signs were within normal limits throughout the course of our treatment. And then a little bit later in the narrative it said, patient is confused, combative, lethargic, or comatose. And get that, or comatose. Okay. Second one, patient position was listed as prone or supine. Third one, a cardiac monitor was not applied. And a little bit later it says EKG shows normal sinus rhythm. So make sure your documentation, when you're reading it, look for inconsistencies. Look to see if the narrative says a cardiac monitor was not applied, and then over in procedure section it was applied. So those are the kind of things you're needing to look between section and section when you're reading it, and this is before you sign off on it. You do not want your name on these kind of inconsistencies. Okay. So now we're going to go over medical necessity. And first of all, Medicare covers ambulance services only if they are furnished to a beneficiaries whose medical condition is such that other means of transportation are contraindicated. So that is a huge word in the medical necessity for ambulance field, contraindicated. So I thought, well, I wonder what contraindicate really means. Exactly what are they saying there? So I looked it up in the dictionary. Contraindicated, contraindicating, medicine, medical, of a symptom or condition to give indication against the advisability of a particular or usual remedy or treatment, to make a treatment or procedure inadvisable. Okay, you get a 911 call, you respond to that call, the patient insists on going to the hospital. Are you legally obligated to take that patient? You don't have a choice, right? So it would be inadvisable for that patient not to go by ambulance because you are legally obligated to take them, correct? So you are the ones that's having to determine advisability. So you're not going to advise that patient not to go because you're required by law to take them. So I think that inadvisability gives us a little leeway there, especially on 911-like calls, where you are totally required by law to take them, so it would be inadvisable for you to tell that patient you're not taking them. Okay. Oh, the other thing I wanted to mention, medical necessity cannot be determined by your opinion. You must consider the patient and their mindset. You or I could not make the call of the ambulance in many situations because we all handle pain, illness, and medical conditions differently. You need to determine whether other means are contraindicated for this patient, for this transport. We know we have a lot of frequent flyers that are constantly calling, constantly going. You have got to get that notion out of your mind of the frequent flyer. You have to consider each run a completely different run, standalone on its own, and not something that they did in the past. We had a problem in Ohio many years ago, where at that time their state law would let their crew not take a 911 call to the hospital, whether the patient was demanding on going or not. If the crew didn't deem it medical necessary, then they could say, no, we're not taking you. So they had a frequent flyer who always called, and so after that rule was implemented, the first time the patient called, the crew refused to take them. Second time patient called, the crew refused to take them. Third time patient called, the crew refused to take them. Fourth time patient called, the crew refused to take them, the patient died. So that's why most states now have the law that You do not turn down a 911 or 911 call. If the patient insists on going to the hospital, you better be taking them, period. Because you never know the complete medical history and condition of anybody you go pick up. You all, you know, you're constantly going here, this patient, this patient, this patient, this patient, and you're on a time thing. You have to do things quickly, You don't get to spend the time with patients that you would need to spend normally as a healthcare provider to assess the situation to the extent that you need to. So that's why it's important that you always take 911 or 911-like calls onto the hospital, because there is no way you know exactly everything that's going on with that patient. There is no way you could possibly know that in the short amount of time that you have with that patient or their family members. So that's what I'm wanting you to look at and make sure that you get out of your head that, oh, this patient has called 50 times, there's nothing wrong with them. Get that out of your head. It's a new run, it's a new day, and just go, do the best you can do, and make the decisions that you need to make for that day and that time. The other thing that I wanted to go over on that is that we do handle things differently. A stub toe to one could be a 1 pain level. A stub toe to somebody else might be a 10. Completely different. So for one of us it would be medical necessity, for the other one it wouldn't be. So that's what you need to understand. You may have a very high tolerance of pain and a very high tolerance of sickness and be able to handle it very well. But the person who called 911, somebody was stressed out, in duress, something wrong for them to bother to call. For whatever reason. If they're anxious, if they're in duress, anything like that meets medical necessity. And chances are if somebody called 911, there's something going on mentally inside of them, and that meets medical necessity. So make sure that you're understanding that just because it's a stub toe may not affect anybody in this room at all, but somebody else could be going crazy on the inside because any little bit of pain they just can't even focus or tolerate it. So just kind of keep those kind of things in mind and make sure you're not putting everybody in the same box. And I had a situation a few weeks ago when I did a training, and somebody came up to me afterwards and was telling me that under no condition would any kind of pain be considered medical necessity. And I said, well, people tolerate pain differently. He said, but it still wouldn't be medical necessity. So I'm like, okay, you know, I don't agree with you, and that's not what the regulation says, but you know, so I went to their supervisor and said, you make sure you monitor this person's runs. I think we've got a problem going on here. So we're not doing this by what we think or how we feel. We're doing this by what the federal guidelines says we can do. And the one thing you have to make sure is that you're being truthful and accurate. That is key. And that truthfulness and that accurateness, you need to make sure you understand it completely on the condition of the patient and how they're dealing with it. And that's why you should always find out what they consider their pain level to be and write that down, because having that information could probably save your hiney some point in time. If you've got that quantitative, qualitative information in there, that would definitely protect you. Okay. So now we're going to go through actual, you know what, let's take about a 5-minute break, 5-10 minute break, and then we'll come back and go over all the different medical necessities. Okay, so now we're going to emergency, now we're going to non-emergency medical necessity reasons. Patient is unable to maintain erect sitting position in a chair for time needed to transport due to moderate muscular weakness and deconditioning. Patient is unable to sit in a chair or wheelchair due to grade 2 or greater decubitus ulcers on buttocks. Patient requires third-party assistance, attendant required to apply, administer, or regulate or adjust oxygen en route. Patient requires IV medication during transport. If that's the case, make sure your treatment section has some kind of IV medication logged in. Patient requires IV fluids during transport. Again, if that's the case, make sure there are IV fluids. Now, what you need to have in there is why was that medication required or why was the IV fluids required? And that's the kind of thing that you use the narrative for. So you've got your IV fluids or your IV medications listed, your narrative should explain why you did it. Okay. Patient requires cardiac monitoring during transport. Why? What's their condition? Why are they requiring that? Patient requires hemodynamic monitoring during transport. Why? Patient requires special handling en route. They need to be in isolation. Why? Patient has contractures. That's fine. You don't need to have any further explanation on that. Patient has non-healed fractures. Where are those non-healed fractures? Now this is critical. Patient is in moderate to severe pain on movement. And again, this is going to be different from patient to patient to patient. Some patients, you barely move them and they're going to scream out in pain. Other patients can take 3 times that amount. So I had one place where they were saying that they went to pick up the patient and she's just tooling around in her wheelchair all down the halls in the nursing home, and they're like, what in the world does she need an ambulance for? I said, well, let's look at this scenario. Maybe she could do that. Halls are nice and smooth, floors are nice and smooth, but if you put her in a vehicle and she's bouncing around, that may cause her some pain, and she can't tolerate that pain. So and that's where I want you to not just automatically, by what you're seeing, assume the worst. Make sure you're trying to find out more about that patient and get information that can determine why they're needing to be transported by ambulance. Due to DVT, patient requires elevation of lower extremity. Here's a good one. You could actually transport me under this one. Due to morbid obesity, patient requires additional personnel equipment to handle during transport. I mean, just because somebody's way overweight, they're allowed to be transported by ambulance and they meet medical necessity. Due to halo orthopedic device, patient requires special handling and transport. That's okay to document it as it is. Due to use of pins and traction or orthopedic device, patient requires special handling and transport. Patient requires, I love this, or is anticipated to require either physical or chemical restraints during transport. So you only have to anticipate that somebody is going to either require a physical or chemical restraint in order to meet medical necessity. Patient is a danger to self or others and requires monitoring. Anything that would require a patient to be monitored by somebody with medical training meets medical necessity. So always keep that in mind. If they need somebody who has some type of medical training, which you do, to watch them while they're being transported, that meets medical necessity. Patient is at risk of falling off of wheelchair or stretcher while in motion, but not due to obesity. Patient is a danger to self or others and requires seclusion because they are considered a flight risk. Again, those kind of people could be dancing to your vehicle, but if they're considered a flight risk, then they meet medical necessity. Then you've got the last 4, which any one of them all alone is fine. Patient is confused. Patient's confused, they meet medical necessity. Patient is combative. They're combative, they meet medical necessity. Patient is lethargic, patient is comatose. So those are all things that meet medical necessity. So that's what I'm wanting you to understand as far as there's a lot to medical necessity, and it's not going to be the same for every single individual. You cannot put medical necessity in a box. It is going to be different for every single person, and it's your job to figure out what makes that person different, what's making that person tick, and which of these categories do they fit into that I need to record. Okay, advanced beneficiary notice. In general, a notifier, you are the notifiers, may not issue an ABN to a patient who has a medical emergency or is under duress. Forcing delivery of an ABN during an emergency may be considered coercive. So and this was a new law that they put out in the end of September of last year, because used to you could give an ABN in an emergency situation, and now they've said that that is considered coercive and you are no longer allowed to do that. So if it's a 911 or 911-like call and you responded immediately, do not under any circumstance get an ABN. If there's a situation where you think that that may not be payable by insurance, verbally tell the patient that. That's all you have to do. Okay, in order to issue an ABN, you have to meet all three of these situations. The service being provided is a Medicare covered service, okay? So right away, we know Medicare does not cover transports to and from doctor's offices. Don't need an ABN. It's not a covered service, so you don't need it. If it's not a covered service, you don't need an ABN. The service being provided is a Medicare covered ambulance benefit. 2, the provider supplier believes that the service may be denied in part or in full as not reasonable and necessary. And 3, the ambulance service is being provided in a non-emergency situation. The patient is not under duress. So basically, you get an ABN when you question reasonableness or medical necessity by 95%. Then you get an ABN signed for non-emergency transports only. And that's it. There's no other reason to get one.
If the patient's not under duress.
I said in non-emergency situations only.
But I want to non-emergency, the patient just be told all places.
Okay, if the patient's under duress, don't even worry about it.
So they must meet all three.
You have to meet all three.
If they fail one of them, then it's out the window. Okay.
Yep. It has to be a covered service. You think there is no reasonableness or medical necessity, and it's not an emergency situation, and the patient's not under duress. It has to meet all three of
I
those.
think that what the problem is with the word emergency is that everything we get sent out on, pretty much, well, there's some schedules run, the tones go off, that's an emergency.
Okay, now, here's the situation with your service that you kind of have to look over. An emergency run is the dispatch complaint requires you to respond immediately because of the condition of the patient could be in. So just because you have an in-house policy that however a call comes in, you're responding immediately does not make it an emergency run. It has to do that the dispatch complaint requires you to respond emergently. You cannot have, Medicare does not pay for protocol. That is an okay protocol to have. That is fine. But your billing company will determine whether it's an emergency or non-emergency transport, depending on that dispatch complaint. So you all don't have to worry about that. Your billing company knows the rules.
Okay, we get dispatched
So
to,
you have a protocol that you always respond immediately to a call.
Okay, we respond to emergency, but we get on the scene, it's not an emergency, it was a shortness of air, we get there, the patient's had.
Well, okay, shortness
So
of
it-
air
it's really-
requires you to
I
respond immediately,
understand
so that is an
But I'm
emergency.
saying, we get there and this patient's had.
It doesn't matter.
Okay.
That
but
doesn't
now-
matter.
But now we go to the ABN.
No, it's not it's not a non-emergency run. That's an emergency run. Even though the
Because it
thing,
came out as emergency.
because of the patient's condition required you to respond immediately, it doesn't matter what condition you find the patient in, it's an emergency transport, period.
Okay.
And that's what I'm saying. If the patient's condition at the time of dispatch requires you to respond immediately, it's an emergency run no matter what condition you find that patient in.
So they say chest pain, we respond immediately, get there, they have.
And they have a
chest
muscle
pain.
ache.
It doesn't make a difference.
No, it's an
because they just
emergency
call for
transport.
chest pain.
Absolutely. Yeah. But if they're calling, and the problem with that is sometimes you don't get enough information from dispatch, and all kinds of scenarios can play out, and so you are required to respond immediately. So in that case, it is an emergency.
And in regard to the ABN, when we're transporting them in his situation, we don't do that because it's an emergency, it
Yeah.
could be considered
Yeah.
coercive,
That's correct. That's correct.
even though we know it's BS.
Correct. So the only time that would come into play is if you're called and it says, okay, you don't have to get here immediately. I can wait a little bit, you know, I've got this I need to have looked at. But your protocol is to respond immediately, then that's not an emergency run. That's not an emergency run, but your billing company would be able to tell that from the documentation. Anybody else have?
Sorry to backtrack, but you said that Medicaid, Medicare patients, or Medicaid, Medicare, will not let you submit a claim for a transfer from like a nursing home to a doctor's office?
No, I said Medicare does not cover transports to or from doctor's offices. Medicaid does.
Okay. All right.
And the ABN is a Medicare form.
So does the PCS really doesn't even matter then, going to a doctor's office, because it's not gonna pay if it's.
Well, it
Medicare?
does matter because you're required by law to get, the only time you're not required to get a PCS for a non-emergency run is if the patient is being picked up at their residence or they're in a facility and not under the direct care of a physician, then a PCS is not required.
So if we pick up a Medicare patient from the nursing home and they give us a PCS states the patient is bed confined, you get to his room, he really is bed confined, he's going to the urologist, okay? Then we can then list medical necessity, and but Medicare still won't pay for that?
That is
Even though
correct.
we're going to a doctor's office?
That is correct.
Well, how does Medicare see suitable for their bed confined patients to get to the doctor's office?
That is a good question. That's a good question for them. And they will blatantly admit, we understand that that patient cannot get there any other way but by ambulance, but we don't cover that modifier. It's not a covered service. And the patients should know that. I mean, they should know that Medicare doesn't cover that. The problem then with that is if the patient were to call, or a patient's family member were to call 1-800-Medicare and say, hey, you know, this is my mom's situation, you know, she can't get to this doctor's office any other means but by ambulance, why isn't Medicare paying for that? And they will say, well, they should pay for that, have them bill it again because they do pay for that in some situations. Well, there's only one time that Medicare pays to go to a doctor's office. And the situation is you're responding to an emergency transport and the hospital is too far away and you've got to get that patient stable, so you stop at a doctor's office to stabilize the patient on your way to the hospital, then Medicare covers that.
Okay, I got a question along those lines, and it happens to us frequently. We go whatever location to pick up a patient. We take them to the doctor's office, and then the doctor admits them from there. Is it illegal for us to show the destination as the hospital, leave the doctor's office out of it, that way it'll pay the bill for the patient, or is that?
No, what I would do is I would have a run going from wherever you picked them up to the doctor's office. That's a run. And then they have a run from the doctor's office to the
Well,
hospital.
Say the doctor's office is in Warren County. We, as according to the rules of our CON, our certificate of need, we cannot have a run originate and destinate, if that's a word, in a county that's not ours. You see, that way the origin would be Warren County, and the destination would be Warren County.
Then why
And
are
for
you
us, that's
taking
a-
that patient from the doctor's office to the hospital if that's the case?
Well, say the doctor's office is on Elm Street, and the hospital is on Hickory Street,
But what I'm saying, okay, you've taken the patient from here to the doctor's office.
and the doctor admits.
Is the patient out of your ambulance and in the doctor's office?
But we
Yes.
have,
How come you're not leaving?
It's they're on their stretcher.
they're on our stretcher and they don't take the patient.
They don't take, and they're not taking stretcher patients, or have room accommodations for a stretcher patient. Therefore, we cannot unload off the stretcher, the doctor sees the patient on our stretcher.
And
That's how they get it.
And then the doctor winds up admitting the patient, so we just take them, put them back in the ambulance and drive to Hickory Street and unload them. Can we show the destination as the hospital, so to pay the bill for the patient? Or is that totally illegal?
Very seldom do we take them off the top when we go to the doctor.
That is a really good question,
Well,
because
it
that's
really
kind of
was.
like a catch-22.
With what she said.
And I don't know that I want to answer that on tape. So we might want to discuss that a little bit later.
The last time that it happened, I instructed the doctor that I have the Warren County EMS to come get the patient. When contacted Warren County EMS, they said that they didn't have a truck and they gave permission for us to take her home to the hospital, so I made sure.
And then that would be a good way to handle that. That would be a great way to handle that.
We put it in the documentation that.
Absolutely, that you contacted Warren County and they said, you take the patient, we don't have anybody available.
So later,
So,
when we're not. on
and that's
paper,
something, yeah. And then, but that's something that you could also work out with Warren County, and say, what do we want us to do in this situation?
Yeah, sure.
And if they, say, enter some kind of arrangement that when this specific situation happens, Allen County, you just take that patient and then you
We
would just
just
do
try
that.
to help out the patient.
Absolutely.
Our rates are not as high as a lot of them, but they are pretty high.
Absolutely. Okay. So I only had one other thing that I just kind of wanted to quickly go over. One of the things that we've talked about in the past is character qualities and how important character qualities are, especially when you're in the healthcare field, because you all are under a microscope of scrutiny in order to get money back into the Medicare funding. And so healthcare providers are looked at in every aspect of their lives. So as a healthcare provider, I just had I made a list. I'm not going to go through this whole list, but I did have a list. I actually have a list of character qualities that are pages, and I got it down to one page. This character just is a passion of mine, and I've been working on it since the early 1990s. But these are just some things that I feel that healthcare providers, in order to make sure that you're very ethical and above reproach in the government's eyes, these are just some character qualities you need to have in your place of employment. Alertness versus carelessness. Being aware of what is taking place around me so I can have right responses. Attentiveness versus distraction. Showing the worth of a person or task by giving my undivided concentration. Your patients really need that. Your patients need to know that they have your undivided attention. Availability versus self-centeredness. Making my own schedule and priorities secondary to the wishes of those I serve. Boldness versus fearfulness. Confidence to say or do what is true, right, and just. Dependability versus inconsistency. Fulfilling what I consented to do, even if it means unexpected sacrifices. Your employer needs to know that you're dependable. Very critical. Endurance versus discouragement. The inward strength to withstand stress and do my best. Discouragement. While we're on that, one of the things I like to do is I don't like grumbling and complaining, especially in a workplace. Grumbling and complaining can bring division quicker than anything. So what if you're sitting down with, and the thing with grumbling and complaining, all that has to happen is one person says something, and then immediately it's just like our innate nature, our instinct to go, yeah, you know, you're right, and come up with something else. And then it turns out to be this huge thing. So what I would suggest you do is if you hear somebody grumbling and complaining, let's say people are grumbling and complaining because of something Ed did. You know, didn't like what he did. And so somebody's grumbling and complaining over that. As a good employee and to do the best for your employer, the best thing you can do is say, hey, but do you remember when Ed did this for us? Look at how many times he's bought lunch for us that they paid for out of the service, or how many times try to think of something good and get off the topic instead of getting it to, so you know you have this huge line of people now grumbling and complaining over something. Always try and flip it around and try to think of the good things. Number one, hey, I've got a job. I have a job. Do you know how many people, if you're dissatisfied with your job, do you know how many people would love to have a job? So just, you know, think of it a little bit different way. Enthusiasm versus apathy. Expressing joy in each task as I give it my best effort. Honor versus disrespect. Respecting others because of their worth as a human being. None of us should ever consider that our worth is in what we do. Our worth is in who we are. So know who you are, and that's where you get your worth from. You don't get your worth from who, you know, what you do. I mean, an attorney has no more worth than a janitor. None whatsoever. We do not get our worth in what we do. We get our worth in who we are. Justice versus corruption. Taking personal responsibility to uphold what is pure, right, and true. Obedience versus willfulness. Quickly and cheerfully carrying out the direction of those who are responsible for me. Punctuality versus tardiness. Showing esteem for others by doing the right thing at the right time. Responsibility versus unreliability. Knowing and doing what is expected of me. Thoroughness versus incompleteness. Knowing what factors will diminish the effectiveness of my work or words if neglected. And truthfulness versus deception. Earning future trust by accurately reporting past facts. And that's where we are on our documentation. You are going to earn the trust of your billing company and those over you by accurately reporting everything that you're supposed to be reporting in your documentation. So if something is not there, you have earned their trust to know that it wasn't there and that they can trust your documentation. That's all I have. Any questions? Thank you very much.